Well, good afternoon, everyone. It's really nice to see you with us today. We are continuing with our Project ECHO, which is a collaboration and a partnership between PallCHASE, a global network in palliative care, focusing specifically on humanitarian settings, along with APCA, which is the Africa Palliative Care Association, and Two Worlds Cancer Collaboration, which is a charity from Canada supporting palliative care growth in different countries in Southeast Asia as well as East Africa. We're really excited to have you with us today. Some of you, it might be the first time you've been with us, and we'd love for you to introduce yourself in the chat. We're oftentimes a group of about 30 participants. So please put your name in the chat and where you're working, in which organization you're working with. My name is Erin. I'm a palliative care nurse originally from Canada, and I currently live in Nairobi, Kenya. And today we are looking forward to hearing a short teaching session from one of our faculty members, and then we will shift over to do our case discussion. This is the Project ECHO model, where we continue to focus on all teach, all learn. So as we welcome our speaker for today, we also know that we as speakers or facilitators also learn from the group. So if you have any questions or any concerns, we would encourage you and invite you to put any questions in the chat. I see here we have Mohammed from Cairo, which is great, part of the Sudanese American Medical Association. Welcome. We have Aiden from Dagahali, MSF. We also have Dr. Ephraim from Ethiopia, our nephrologist. So it's great to have a wide variety. We have someone from Hospice Africa, Mutebi in Uganda, and as well IOM in Sudan. Welcome, Saku. It's great to have you all with us today. Just a few reminders. We will do the teaching session for about 20 minutes at the beginning. So we would love it if you could just remain on mute. If you do have a question, of course, you can put your hand up in Zoom, and we'll definitely get to your question. If you have any questions or comments, you can also put them in the chat while we're doing the session. And I am going to pass it over. I wanted to introduce our speaker for today. It's a collaboration effort. The original session was supposed to be taught by Sarah Raynaud. She's on the call with us today, but she's not able to teach this session. But Sarah is a palliative care nurse originally also from Canada. She's been living in Kenya for the last several years and has been supporting palliative care work in humanitarian settings with our team here in Kenya. Sarah helped create the slides, and we did a co-facilitating model today. We have Vilma, who will be presenting the session for us, and I'll be taking over a few things related to physical symptoms. Vilma has been a faculty member with our team for several years now, I think. She has been involved in East Africa through our ECHO training. She works at a local hospice in Canada, and is very passionate about supporting caregivers and patients in the community. And I will pass it over to you. Vilma, did you want me to share my screen? I can't remember what we talked about.
That's fine if you want to do it, because that way you can continue with the case as well.
Yeah, perfect. Okay, so let me share my screen. Vilma, please extend your introduction of yourself if there's something that
Yeah, okay. Hi, everyone. Thank you for being here. I work in a community hospice in Ontario, so very close to Toronto, and I do home visits and support people to stay at home, people who have a life-threatening illness or people who are bereaved as well. So yeah, thank you for having me here, and I love this work, so thank you. I cannot see the screen. Let me
sorry, let me reshare it.
Maybe it's my own fault. Maybe it's my own fault. Give me 1 second.
Can you see it now?
Yes. Yeah. Do you have the whole thing with the slides on the side, or do you want to do the full screen? Yeah, maybe. Okay, there we go.
Great.
Awesome. And do you want to do the first part, or?
Sure. So today we're going to be focusing on holistic palliative care. So understanding how to implement palliative care for our patients and families in a holistic way. And we'll be talking about some different theories and then also how to apply that to the work that we do. Again, this is a collaboration between Two Worlds Cancer, Africa Palliative Care Association, as well as PallCHASE. We do want to give credit to our team in Two Worlds as they support us as we continue to develop content in this area, as well as the team at PallCHASE. And as we continue to do teaching on palliative care, we align our method with the palliative care core curriculum that is endorsed by the Africa Palliative Care Association. So you can get some more information there, and I can share these slides at the end of the session. Over to you, Vilma.
Great, thank you. Okay, so by the end of the session, you should be able to define a holistic approach in palliative care, understand the benefits of a holistic approach, and also apply this holistic approach to pain management in palliative care. So what is holistic care? It is the treatment of the whole person rather than just the symptoms of the disease. And this is something that I try to, when I'm meeting with people, just get to know them, really, like who are they? Not just a patient with cancer or a patient with this or that, right? Who are they as a person? That way we can address not only the physical aspect of the illness that they're facing, but also the emotional, social, and spiritual needs that the person has. It is a type of care that is comprehensive rather than aiming just to treat the illness. It enhances the overall well-being and the quality of life of the person and the family, right? Next, Erin. What are the benefits of this approach? As I said before, a comprehensive care, right? We focus on what the patient and the family need. We also can help with prevention, right, of things getting worse, even with the anticipatory grief, everything that is involved, and promoting wellness. And also, it allows us to integrate different modalities and empower the person. Also, they feel, the patients and the families feel that they are actually being included. They're validated, their wishes, their approaches, their beliefs, everything is included in the care. And also, we promote self-care, right? Because it's not only about the person with the illness, but also the caregivers and everybody involved in the care. Collaboration and coordination. They feel like they are part of the team. And of course, if they are involved and they feel like they're valued and they are providing input, the outcomes are improved. Next, yeah. This is you.
So as we think about holistic care of our patients and families, especially in humanitarian settings, we encourage that you begin to consider the physical, so that they're on the left side, the spiritual, the psychological, as well as the social. So if you have attended any sessions or trainings related to palliative care, you may have heard these areas before. It's actually very critical to the type of work that we do. In palliative care, we know that a multidisciplinary approach is really important, yet we as providers are able to consider and actually provide this type of care to our patients on our own. So if you are a nurse, you can address the physical aspects of a patient, but also consider spiritual aspects. And when we think of suffering, we think of suffering related to social, even psychological suffering of our patients. So this is really important as we continue in the session today to think about the type of care and the model of care that we provide to our patients with these 4 different areas. So I'll start on the physical. So when we prioritize a holistic approach to the type of palliative care we provide for our patients, we initially focus on managing their symptoms, such as pain, nausea, even shortness of breath. We know that there are some challenges, though, that come and are included in addressing this type of these issues with our patients. We know that in humanitarian settings, there's often limited access to medication. It could be medications like morphine, which we talk about extensively in terms of treating advanced pain or severe pain. But it could also be access to oncology medications. We know a lot of our patients in refugee camps or in remote settings don't have access to curative care. Even treatment such as dialysis is very limited in humanitarian settings. We know that there are challenges related to shortage of equipment, even we sometimes lack trained healthcare professionals. So as we try and as we aim to provide holistic physical care, we know that there are some things that will be barriers for us in these settings. Yet, as we move forward, as we work together, there are specific things we can do in our settings, regardless of the challenges that we have. So we will continue in the session today to talk about different tools that we can use. So assessing physical symptoms can be done with very limited resources. Often just a clinician and a patient, where you can ask the patient and assess their symptoms. You can document and record them. We can use the WHO pain ladder to address pain in patients, as well as really focusing on non-pharmacological interventions. For example, for shortness of breath, we often recommend opening up a room, making sure a patient has access to a window. Using a hand fan or having someone fan a patient can really reduce the symptoms of dyspnea or shortness of breath. On to you, Vilma.
Thank you. So the other aspect that Erin mentioned, like what we can see here for holistic care is the psychological care. And we know that when we are facing an illness or when someone we love is having a difficult time, or when someone has, is close to the end of life or anything related to that, a lot of stress can come out of that, right? And with the psychological care, we're going to focus on that emotional distress, the anxiety that comes with everything that's happening, even depression, right? For the patient and for the family, the fear of what is happening and what will happen in the future, and of course the grief, anticipatory, and even after someone has died. Some of the challenges that we encounter, it can be the stigma around death and dying, and we've mentioned this before, Erin. I've heard this too, that in some cultures, for example, people don't talk about death, or maybe they don't share a diagnosis with the family, right? And that can be a lot of stress for the person who's facing the illness, not knowing what's happening, and for the family as well. There can be also limited access to mental health professionals. So we sometimes don't have anyone to rely on or consult with. The approaches, of course, if there's counseling available, that's always helpful. But in a lot of settings, we cannot find that. So support groups are beneficial. And as I mentioned before, in my work in community hospice, we usually see how peer support is so beneficial for people, just knowing that there's other people who are in a similar journey and that they are not going crazy, that they can rely on each other. That's always very helpful. any mental health services that we can find, in providing safe spaces for sharing and engaging with others, as I was saying, with peer support, right? Yeah, the next one, Erin. And this is very, psychological, mental support, and all the care that we can provide is definitely linked to social care. This aspect focuses on maintaining social connections, and isolation is huge, and especially when people have been displaced, like we can see here on the challenges. People are new to this environment, maybe they don't know anyone around them, so supporting them in addressing that isolation, providing practical assistance. Maybe they had supports where they came from, or they're very isolated, remote areas, so helping them find the supports, connecting patients and families with their communities. Maybe they don't know where to go. And I find that even, in big cities, people don't know where to go. So that information is key for them to find those connections. And of course, the challenges, right? As I said, displacement, loss of social networks. If they're refugees, if they're in a camp, or if they have been relocated, they don't know the people around them. And there's also cultural barriers, right? If you're in a new place, maybe you have these beliefs and you don't feel comfortable even sharing if you have the support. So helping people connect with similar people who have a similar cultural background, or people who speak their language, it makes a huge difference. Approaches, community-based support networks, if we can find them. I'm always open to, learning from the person that I'm seeing, right? And asking, like, who do you go to? Listening to them, like, do you belong to any groups? What are your hobbies, or things like that? Because that way I can try to connect them with people who maybe have similar interests, or who have knowledge of their culture, their community, and they can connect with each other. Any support groups, any social inclusion, right? Inviting them to participate. So there's a lot that we can do, and you all know your communities, right? And every community is different. So getting to know the area where you're at and where you work is key for improving the social support that you offer. The next one, Erin. And the other area that we're mentioning here as part of holistic care is the spiritual care. And this one, it focuses on acknowledging and addressing the spiritual and existential needs of patients and families. And of course, we respect their diverse religious and cultural beliefs. And you're going to see here, like, this is the first time that I'm mentioning active listening, because it's so easy to make assumptions, especially in this area, right? Just because someone belongs to, or is a member of a certain group, or maybe comes from a certain culture or background or country, we may assume that this is what they believe or what they need. And that the best way to know is by engaging with them and learning from them, because it's not just about faith, it's about the meaning of their life, right? Their whole existence. And people start questioning all of this when they're close to the end of life, or when someone dies. So the challenges, of course, cultural differences, the lack of religious and spiritual resources, whatever they may be, and the service provider's level of comfort, right? So you have to be comfortable with asking questions, in hearing maybe, the stress or existential crisis, or whatever's happening with the patient, in order to support them and help them in this area. Engage approaches, engaging chaplains, spiritual care providers, creating sacred spaces for prayer, reflection, whatever that may look. Support patients and families in their search for meaning. And we'll talk a little bit more about this as we go. Thanks, Erin.
So we're
Now
gonna
back to you.
Perfect, thanks. We'll take a look at pain management from this holistic lens. So we want to, as a group today, acknowledge that pain is more than physical. This may be the first time you've heard that phrase, and some of you I know are seasoned palliative care providers, and you know this is true. But today we wanted to describe and share the concept of total pain or total suffering, which comes from Dame Cicely Saunders, who was a pioneer in hospice and palliative care in the UK. And she shared and believed that physical symptoms were only one part of a person's experience. The emotional, psychological, social, as well as spiritual factors also contribute to ease or, in most of our situations, the difficulty with which we experience quality of life. So we know that all four components interact with each other to potentially increase stress and physical pain. So you may have a patient that is experiencing pain as they have subjectively shared with you as their clinician, and you're trying to really understand, what does that pain look like? What does that pain objectively look like for this patient? We know that pain is a symptom that is reported by patients, and it is what the patient says it is. We know that medication often can treat physical pain. We know that medication is not a good use to treat emotional, social, or even spiritual pain. And this is why it's really important, especially with our patients in humanitarian settings, whether they're internally displaced people, whether they're refugees, they have 100% experienced some sort of trauma, whether that means they've had to be force migrated to another location, whether they've experienced loss of a family member. We need to continue to acknowledge in our work in these settings that our patients are experiencing more than just physical pain. So here we can see from a holistic approach, we'll go back to those four domains that we were talking about earlier: the physical, the psychological, the spiritual, and the social. So if we think of pain as the main symptom or the main issue that we're thinking of right now, the physical pain that our patients experience can be caused by their illness. So if they have advanced cancer or if they have severe arthritis, that is a physical cause of their pain. Sometimes our patients have pain based on treatment. Of course, we have a lot of our patients in humanitarian settings that are post-surgical. So they'll have, of course, surgical pain, and even comorbid factors could cause pain. As we move on to the psychological, we need to, as clinicians, and I know most of the people on the call are, continue to acknowledge that our patients will experience pain related to anxiety. So it could be related to anxiety about the past. It could also be about the future. It could be a psychological fear of suffering that's causing severe pain in our patients. It could also be from a mental health issue, such as depression, or just serious sadness and grief and loss, just as we talked about earlier. Our patients experience spiritual pain as they continue on their journey of living. They may have lost their faith. They may be angry with their higher power that they believe in. They're trying to find purpose, which can cause pain. Maybe they've never been in a situation like this before, and they are experiencing spiritual pain because of the fear of the unknown. And all of our patients, whether we acknowledge it or not, experience some sort of social pain. Being a patient means that they have potentially lost their role, whether it's their job or their social status. Maybe it's even their status within their family. They used to be the leader, and now they are having to receive a lot of support from caregivers and family members. Many of our patients, if not all, have financial concerns. Oftentimes, living in a humanitarian crisis leads to serious economical issues for our patients and families. And many patients worry about the future, and this can lead to pain of our patients. As we mentioned earlier, pain is a subjective symptom that we need to ensure patients report. They tell us their symptom of pain. In terms of physical pain, this is the physical symptom that's caused by illness, treatment, or those comorbidities that we spoke about earlier. When we think of an approach, we use medication to treat this type of pain. We need to use tools to assess a patient's physical pain, and we also can provide, at times, physical therapy, so exercise and stretching when appropriate. So here is an example of a scale that we use often for children that are young to help them describe what their pain is at the moment. We can also use a scale of 0 to 10, asking patients to rate their pain when it's minimal or none at all compared to when it's very severe. So this is an example of the FACES pain scale. It was from the International Association of the Study of Pain. In the blue there, you can read what you are supposed to say as a clinician. So you would say these faces show how much something can hurt. This face, and you point to the one on the very far left, shows no pain, and that's the 0. The faces show more and more pain going from the left to the right up to this one. It shows very much or the most pain. And now we ask the patient directly, point to the face that shows how much you hurt right now. And at this point, we would allow the patient to point to the face, and then we would help them score their pain. 0 would be no pain, and 10, of course, would be very much or the most pain. We try not to use words like happy and sad as we describe pain, and it is not intended to put beside a patient to see if it looks like the way the patient looks like, because we actually want the patient to score their own pain. We want them to be sharing the pain as a self-reported symptom. And that was just one aspect or example of how we can address and begin to assess pain that is physical. And now on to you, Vilma, for social pain.
Thank you, Erin. So as humans, we need community, right? We need companionship and a feeling of belonging. When this is not happening, we feel the social pain. And the one thing that is very common when people are experiencing something difficult, like an illness or grief, is that they feel that they're isolated, that no one else understands what they're going through. And this is painful. And sometimes the people around you or around the patient, they don't get close because they don't know what to say, how to support people, how to, they don't even feel comfortable. So it is part of our, role as professionals to try to include as many people as we can in supporting the person and the family. In this social pain, as it says here, it can include the loss of, the loss of family, especially when, if you're working in a humanitarian setting, right? If it's people who are refugees who have been displaced, maybe everyone was left behind, or maybe everyone died, right? If they come from war. The loss of the community. Now they don't have that community that they used to belong to, the role that they had, the loss of the job. So all this, in addition to the physical pain, it's a huge load to carry for people. Financial worries, all the anticipatory grief that the person experiences, and this includes, now knowing, if they're aware that they are going to die, they're going to leave their families behind. Maybe, they're not going to see their kids grow older, or they're not going to be able to achieve their goals. So in this, as we saw on that, the diagram, everything connects to each other. So this social pain increases the physical pain that they might experience, right? Because that pain is not due to the illness per se, but it feels worse. Or the mental, right? The anxiety or the stress that this causes. The approach, when we meet with patients and families, to be open and to have compassionate communication, right? Active listening, as I said, listening to what they're actually feeling their experiences, asking questions, having those difficult conversations about death, about fear, about plans, about everything that's happening. And we sometimes don't open the door because we are not comfortable with that. Eh, but we have to remember that allowing allowing them to talk about this can bring relief and opportunities to build connections, to find meaning in what they're going through, and not only for the patient, but for the families as well. The next one, Erin. And as we said, right, everything's interconnected. So if we are not finding that meaning in our community, in our life, we're going to have that spiritual pain. And it can include the loss of faith or the anger with God, if that's part of their beliefs. If people questioning, why is this happening to me? Where is God? And I've heard people say, if there was a God, right, even if they were very religious or had a very strong faith, if someone, let's say a child is ill, right, if there was a God, my child wouldn't be going through this, or I wouldn't be going through this, whatever it's happening to them. Or even if they are not religious, the inability to find purpose and meaning is just, what's life for? Like, why have I, why did I do everything that I did? Maybe they come from a very hard life, and they're finally seeing the light at the end of the tunnel, and then this happens. So why did I do all this? Nothing's worth it, or and that can lead to depression, to other, the existential distress. So allowing them to talk about this. And the approaches, as I said before, active listening, asking questions, listening to what they're saying, really listening to what they need, empathy, compassion, and maybe talking to a spiritual or religious leader if there's someone available, and connecting them with the right supports. If it is important for them, reading scripture or any spiritual books, right? Maybe, we are not, we don't believe in the same thing, we don't have the same faith, but if that's what's important for them, we promote it, we support them in what they need. Supporting them in attending maybe worship services, praying, connecting with nature. Sometimes, people just need to go out in the, it doesn't have, as I said, it doesn't have to be religious. It can be just seeing the world, right? In appreciating what's around them, whatever that may be. Or maybe doing legacy work. Maybe it's that worry about, my kids are not going to know who I am or who I was. So allowing spaces for them to share that, to do some legacy, and know that they're not going to be forgotten. The next one, Erin. Emotional or psychological pain, which, as you can see in this image, it's very hard to differentiate them, because, it's the experience that people are having. It can include the loneliness, feeling that they're going crazy, that no one else understands what's happening to them, despair. It can lead to depression and anxiety. And I see, and I've seen many times that, as Erin said before, there are certain things that can be managed with medication. But in these cases, and sometimes, it's easier to prescribe something than to listen and address what's happening with the person. And maybe that's what's going to be helpful. Maybe that's what they need, and not necessarily another pill, right? So helping them with sharing what they're going through and addressing that and finding meaningful ways to overcome whatever's happening. It if we don't do that, it can lead to any other mood disorders. Maybe they can worsen the physical symptoms, right? In they can now start having trouble sleeping or difficulty concentrating or even panic attacks, right? Like feeling that this is it, I'm dying right now, when that is not really happening. In if we promote a space where they can be listened and they can share what they're going through, their feelings in their fears, and we support them with empathy, compassion, and find them that community support that they need, it may be these symptoms are gonna decrease, and they're gonna be able to be calmer and to find meaning in what they're going through. And if we have counseling available, if we feel that that's what might be beneficial, of course, but I don't know if there's a lot of counseling services available for a lot of our patients. Yeah, next one, Erin. You want to do this one?
Sure. So just as we come into our time of discussion, we want to ensure that everyone who's on the call or listening to this after really understands that palliative care strives to improve a person's quality of life when a disease or a sickness potentially is incurable or untreatable. We know that many of the patients in humanitarian settings where we work don't often have access, so therefore sometimes a disease could be curable, but in the situations we find ourselves in, we have to consider a holistic approach. And this includes end of life, death, grief, bereavement. And the main focus of this type of care, holistic care, in palliative care, is that we can support patients and families with compassion, empathy, and do it in an inclusive and person-centered way. We know that as we continue with our monthly sessions and teachings, we need to find ways to meet the spiritual, social, physical, as well as the emotional needs of our patients. And all of these things we do to try to improve their quality of life. It is really, really central to the type of care and the work that we do. And we know that many of you do this in your work. And hopefully today we've just been able to reinforce some of the things that you're already doing. Some of you, again, these might be new topics or new concepts, and we would challenge you to find ways to integrate maybe one or two new things that you learned during the session today. So in summary, with Vilma and myself, we were able to define what a holistic approach within palliative care is. We talked about total pain and how to manage that pain through a holistic lens. And then we also talked about the benefits or the ways that we can approach our patients with holistic palliative care in mind. So we're going to put a question out to you all. And of course, now is our time for discussion and questions. What can you think of that are other areas that you could incorporate into a holistic approach? So what are other areas of your work or needs of patients that you think we could consider incorporating into the work that we're doing? So as we think about the different types of care that we can give, considering a holistic approach, what else could we include? We know that the symptom burden of many of our patients in humanitarian settings is quite high, and we as caregivers and clinicians don't oftentimes have a lot of time to necessarily address all of these issues that we've talked about today. Anyone have an example of even potentially when they were trying to integrate holistic care, and how did it go? Okay, so we have a question from Susan. Thanks, Susan. Asking about cultural issues in palliative care. Is there something specific that you're thinking in terms of cultural? Maybe how do we address cultural issues?
I don't know about the question, Erin, but it seems to me like one of the things, at least that I have encountered, is that the area where I work is very diverse, right? So always trying to be mindful that the way I see things is different than the way that people maybe see things. So with that awareness, just coming in and trying to learn from them what they need, right? Because again, we all have our assumptions and our biases, and trying to leave those behind and just see what works for them, which might not even be close to what would work for me, right? But we are there to support the patient. It doesn't matter what we believe or our background, right? But I don't know if that is the question, or
I
if
know a
there's
lot of
anything.
times, yeah, I know a lot of times in our humanitarian settings, we often, the frontline providers may not be from the same culture as the people that are being displaced. So I'm wondering, Susan, if your question is related to how do we approach or think of cultural issues that may come up when we are providing care for patients. And I know, of course, palliative care can be very difficult at times. It can be very overwhelming trying to support patients as they're suffering. I think it is really important for us to acknowledge any of our own cultural, just an understanding of our own culture and our own beliefs as we provide care to other people can be really helpful. Leah, I saw your hand was up. Do you want to unmute?
Yes, good afternoon, everyone. My name is Leah from IRC Kakuma, and I'll start by appreciating the topic of today because it has really made me understand how to go about the holistic care. And if you guys can allow, I can share a scenario that I encountered in the field.
Yeah.
Yes. There's this lady who was having cervical cancer, and it just came to my notice when it was in the late stages. And at this particular time, this lady had been discharged and she was in the community. So one of the community health promoters came and told me, Madam, there is a woman in the community and she can't move and she has wounds and there's no way the ambulance can reach closer to her home. And no one wants to carry her to the pickup point. So I was surprised because at that particular moment I had not met this lady and I didn't know what was the case. So I inquired her name and her history of being hospitalized. And I contacted a doctor from where she was last hospitalized. And that's when I came to realize that she was in advanced stages of cervical cancer in any situation. So we took some gloves and spirit and just a few things for home based before we transported her to the pickup point. Then we went, cleaned the wounds that were really oozing with the discharge, and then we put her on a wheelbarrow and escorted her up to the pickup point. I knew the driver of the ambulance was not going to agree because the driver came with other patients in the vehicle when I called the driver. So I knew the case was not going to be well received. So I told the driver, can you just drop these people and then come? Just come direct and pick her alone. So that is what the driver did. The lady was taken to hospital. I contacted the doctor. She was well received because there was nothing much the doctor was going to do. The doctor requested me if she can discharge the lady. So I really requested the doctor to allow me prepare the community, whereby now I was bringing in the spiritual bit of it, the social part of it. I was also bringing in friends. I just wanted this lady because whatever made her become critically ill was those aspects were missing. And to my surprise, no one wanted to come in. When I asked where did she used to go to the hospital, nobody wanted to do that. Okay, call me community leaders. Community leaders were not supportive to come. So when we did a meeting with the community leaders and a few of the neighbors, so to their understanding, it was like this lady might have done something wrong. So this is a curse, this is a what. So in the process of us discussing, I realized that we started late. We started late when the situation was just too bad. And unfortunately, the lady died. So with today's knowledge, I've come to understand we need to start from the word go when a patient is still strong enough to bring this other aspect so that the patient can have an holistic approach to the case.
Yeah.
Thank you. Yeah.
Thank you, Leah, for acknowledging. I think that situation is very powerful to share about the woman who obviously not only was experiencing physical pain, but it was also having a lot of stigma from her community and even from the healthcare workers, or like you were saying, you anticipated that it was going to be hard for even your colleagues to support her. And I think that's probably the first step, Leah. It sounds like you are definitely a leader in your area, and you acknowledge those things. I think as we continue to try to give the best to our patients, I think it is exactly like what you're saying. We have to think of these things ahead of time. We have to think of ways to approach it, to support patients as they are suffering, for sure. Thank you so much for sharing, Vilma.
Yeah, I just wanted to say, Leah, thank you for sharing that. And we always just try to remember for you as a care provider, right? Like we do the best that we can with what we have. And sometimes we are there really late, but patients appreciate so much. Maybe just someone at the end coming and having that compassion and just knowing that someone cares, no matter at what point in their journey they are, right? So whatever you did, maybe that was the piece that was missing that allowed her to, know that her life was valuable, right? So thank you for everything that you did, Leah.
Thank you too.
Yeah, one of the phrases we talk about in palliative care is witnessing suffering. And it's quite interesting. Of course, not everyone on the call today has taken up the torch of palliative care or supportive care yet. We know you're on the call with us because there's a bit of an inkling for you. If not, you're very committed. But one thing I think that we are called to do as palliative care clinicians is to witness suffering. And I think there's so many times we can walk away and we can be discouraged and very down, feeling like there's so many injustices that we just can't approach the situation. It's too overwhelming. And I think, Leah, it seems like you and your team were really trying to find a way to ensure that the patient wasn't alone in her suffering. There wasn't, like you were saying, a lot that could be done to cure her situation, that could be done to fully alleviate every bit of suffering she was experiencing, but you were there with her. You cleaned her, you brought her to a facility, you then escorted her back to her home setting or her community. And I think that shows a lot about your maturity in terms of supporting patients in really, really difficult situations. And I think we can definitely learn a lot from that. Susan? Did you want to unmute, Susan? I see your hand is up. I'm not sure if you're, I can't hear you. I'm thinking, Susan, maybe your microphone is not working. If you wanted to try to unmute. There's a few really important comments in the chat if you have time to read through. Annalice is sharing holistic care can be given anywhere to patients, especially those suffering from conditions or disabilities, even in orphanages, or where we find patients sometimes in old age homes or in communities where there's many elderly people. Elizabeth commenting how it's so important, especially in wards where our patients, sometimes children are alone and they don't have family members with them, to make sure we bring in child life or social workers to support them, ensuring we find ways to bring families together while their children are suffering or before they die. Really, really important. Really good comments. Lamek also sharing about cultural issues. And ensuring that we assess and come up with a proper approach to treat it. For sure, sometimes it's good to let the patient know that some treatments may not correspond with their culture. I think you're right, Lamek. Sometimes we have patients where maybe their beliefs don't align with a treatment, and it's really important that we bring awareness to that so that they can choose, and that it's patient-directed and patient-centered. All right, lots of really, really good discussions. Vilma, I'm going to let you kind of watch the chat for the next little bit. We're going to now switch over to the case. And I know some of our other faculty members are on the call as well. I see Dr. Zafora Ali, as well as I thought I saw Sarah Raynaud. If she's there, you guys can also potentially chip in into the chat if I miss something. Okay, so we are going to move over to the case now. I'd like to introduce Annalice Otoro. She is a senior palliative care nurse that's currently working with International Rescue Committee in Dadaab Refugee Camp in Kenya. She is one of our faculty members as well, and she has continued to be a strong voice for palliative care in her workplace, as well as through our Project ECHO, now spanning to many different countries in East Africa. Annalice is a very committed nurse. She's been working with IRC in the refugee camp for many years, and we're really looking forward to hearing the case that she's going to share today. Annalice, would you like to unmute? And I can share my screen. Welcome, Annalice.
Yes, sir.
Karibu.
I'm in a bit noisy place.
Over to you, Annalice, your turn.
You can't hear me?
We can hear you. Go ahead. Go ahead.
Hey. Hello?
Can you? Yeah, you can go ahead. Are you able to see the screen?
Can you hear me, Erin?
Yes.
Okay.
Okay, Karibu, welcome.
Yes, good evening, good afternoon, good morning, all. I will not repeat my name, Sir Annalice. I'll go straight to the case questions. I was wondering how can we best manage the multiple distressing symptom of this patient, and what is the best model of management for the family? Was the initial management the best for this case? If not, how could it be improved? Then what do do when you find yourself feeling confused about patient's motivation and ability to continue living, when it seems it should perhaps be the other way around. Yes, another. So our patient was 25 years old female with diagnosis of maxillomandibular carcinoma, which was diagnosed in October, and the patient has stayed with the condition. Other diagnosis on admission, the last admission on 8th of December was septic facial wound and then severe anemia. Next. So the treatment and significant investigations, polimogram was done, WBC was 17 millimeter per meter cube. Then RBC was 2.01%, which is low. HB was 7 grams per deciliter, was low. Thrombocytes were 650, which was very high. Then UC's potassium was 2.6, which was a bit low. And sodium was 102, which was normal. Calcium was 122, normal. Urea and creatinine were not done. Then LFT's liver function test was normal, with a few traces of bilirubin. Then patient and family declined any further electronics, X-rays, and ultrasound. Then treatment was given antibiotics, IV, ceftriaxone 2 grams PD for 5 days. Then for pain management, because the pain was in severe pain, actually was in total pain, was given morphine IM 10 milligram BD for 3 days in combination with the IV PCM paracetamol 1 gram TDS for 3 days, for the as need rose, because the patient was spiking temperatures, so we could admit when the temperatures are high. Please, when the temperatures are high, we could give another dose of paracetamol. Then for anemia, the patient declined transfusion, so we managed with the oral ferolic 200 milligram TDS, and then to prevent constipation, we gave Jolclax 10 milligram BD. For the wound, which was having maggots, we cleaned with normosaline. Sorry. Then we dress with the honey mixed with the flagyl twice daily. Next. Sorry. On assessment, holistically, patient was in total pain. With severe mood swings, the patient, you could go there, you find the patient is irritable. Next time you find the patient is in depression. Another time you find the patient is excited. So, and she had eye pain due to the compromising of the condition. The patient at a time, she could develop diarrhea and vomiting, alternating with the constipation. She had insomnia with the irritability, poor feeding, wound with maggots dropping through the mouth. That's, I think, which caused the poor feeding, because you cannot feed with the maggots coming out of your mouth. Then the treatment for pain was initially managed with the IM morphine, but on discharge was changed to oral morphine syrup, 10 milligram QID. And then haloperidol was to manage for nausea and vomiting, and then also was to improve the sleeping habit, and then was to counteract the effect of haloperidol. Then constipation was managed non-pharmacologically with the avocado. We realized that when she take avocado juice, she'll have loose stool. So we encourage her to be using, when she feels constipated, she use the avocado juice and then she will have loose stool. That's how she's managing, and the frequent sips of water, because she cannot take anything solid. The patient is taking only small sips of fluid. That's how we managed. And then we gave her plenty of ORS and the zinc when she has diarrhea. Then the nutrition team supported with the making for her puree, and then also instructing the family how to do it. And then occasionally artificial feed they purchase. When they get the funds, they purchase. And then alternative, they won't care. That's when we dress today, tomorrow will not dress. That's how we are continuing up to now. Next. Then the psychological concern is that the patient who was married, was once married but had no children, when the condition worsened, she married only for 4 months, and then she was divorced because of her condition. And then now she was wondering whether she will have children or not. So where the involvement of mental health psychologists helped to improve her status. And she's still on counseling sessions every time, at least 2 weekly. Next. The family concerns and dynamics was the family feels exhausted, as despite having traveled a very long way with their loved ones, they have traveled to different countries and severally to different health facilities in the country, but still the condition worsens day by day. They speak of life being unfair to them. They had hoped that the several operations physicians had suggested and some performed on her will improve their loved one condition, but it wasn't. And up to now, they have not gotten the solution. So all this contributed to a worst state physically, spiritually, emotionally, psychologically, economically, and even environmentally, because due to stigma, they had to move. When they were going outside for medication, when coming back, their home is no longer there. So they have to again to move to another location and they acquire a new house. So that's how the environment has affected them also. Communication, we managed to use this family has peaceful members, require calm and gentle communication. Where, as a multidisciplinary team, we managed to employ all the empathetic, empathy, active listening, because even she could talk endlessly, but we had to give her an ear, and then she will talk until she finished. She'll cry sometimes. The parents will cry, but we managed to calm them down through the multidisciplinary team. But at our hospital setting, privacy is very minimal. So we talk to general things at the hospital, and then on discharge, we managed to visit at home. We visit at least every 2 weekly. We visit them and we listen to them. That is when we can now employ the spike. We prepare the environment for When we visit them, the environment is calm. They are in an enclosed place, so we can sit and talk, because also language barrier is not a problem now, because they can at least speak Swahili and English. So you don't need a translator in that. Then the patient has a hearing disability due to the infection. So you have to speak loud for her to hear what you are saying. But all that we manage to accommodate in a peaceful way. Sorry for that. Then spiritually, the patient holds strongly, and even the family, they hold strongly on their faith, as she speaks of where Erin, people entering, please, they are interfering. I can't see the screen.
Is it okay now? Can you go ahead now?
The family believes that God's time, will, and way is the best. The father says God's will to heal her or take her away from the earth. He has no objection, since they have tried their best almost 9 years from the time she was diagnosed, and we have spent all our resources and now depend on others for daily basic needs. Patient and family declined any other further referral, stating, "We have gone to India, Turkey, Mogadishu, and Nairobi many times, yet no solution. If God wants to do His will, let Him do." But they normally invite the spiritual leaders and they hold prayers together, they read the Quran, and that's their daily life. They stick on their faith. Next. The current collaboration and the partnership in care is multidisciplinary care and meetings still ongoing as needed. Wound care and home visit alternate days, because the patient can come for dressing at the health facility. If she came today, then after another day, the nurse and the team will go to the home and do the cleaning there, which is not also very hygienically, but we just try our best, depending on the available resources. Then mental health, psychosocial counseling 2 weekly, then visit to eye clinic 2 weekly, nutrition team review, assessment and support monthly, laboratory investigation of full hemogram, UC LFTs monthly, spiritual care daily with close spiritual leaders, but monthly for major chefs. Then logistics, the ambulance sometimes will provide alternate days for visiting the home or bringing the patient to the hospital. Next, Erin. So summary of the case, this is a 25-year-old female diagnosed of maxillofacial tumor for 8 years since 2015, has undergone 3 operations, chemotherapy, radiotherapy, and traditional medicine without improvement. Since the onset of her condition in 2015, she maintained her faith with regular prayers facilitated through several spiritual leaders, has sought multiple medical options within and out of the country to seek help, but in vain. Patient and family have surrendered all to God, while still now entrusting management to be at the local health facility with local available resources as they wait for God's will to be done in His way and His best appointed time. Next, Erin. So we revise our questions as we meditate and think of how we can help. How can we best manage the multiple distressing symptoms of this patient? What is the best model of management for the family? Was the initial management the best for this case? If not, how could it be improved? What do you do when you find yourself feeling confused by a patient's motivation and ability to continue living, when it seems it should be perhaps the other way around? It's like, okay.
Thank you, Annalice, for
Thank you, I'm finished. Oh, I'm in a very nice place.
Thank you, Annalise. Thank you for sharing. So I can put the questions on the chat. But any initial thoughts from the group? You can, I know Dr. Ali is with us. We have a few other colleagues who are experienced in palliative care. Any initial thoughts or comments? This was a pretty complicated case, or still is. I think the patient is actually still alive. And I know it's been quite overwhelming for Annalice and her team as they continue to provide, yet the patient's suffering continues. So here are the questions. What's the best way that we could manage some of the distressing symptoms that the patient has? How can we support the family, and what's the best model to support the family? Was the initial management the best in this case, or could we have improved? And then as a provider, as a frontline provider like Annalice and her team, what do we do when our patients seem motivated to continue to live despite the amount of suffering that they have? How do we continue to be motivated to care for our patients when they go through such severe suffering? Dr. Zippy, do you have any thoughts?
Sorry, I also have something printing in the background, so that's why I'm not putting my. It will be making. I think I don't know how do we get motivated. Yes, I think first of all our motivation is. Can you hear me? I'm seeing you training me. Okay. Motivation, I think, is that we want to see a patient's quality of life improve, and we want to do the best we can. Although I think it's also very difficult for people working in the situations where Annalice and her colleagues are working to be able to do everything possible for the patient. But one of the things is to make the best of what you have, and to remember that there's always something we can do. I think at the beginning of the session, we were told that the doctors, whoever the initial doctors said there was nothing that could be done for this patient. But in palliative care, we always say there's something that we can do for our patients. So even just being there physically for that patient, and we talk about just being there already starts improving the patient's morale, that somebody cares, and especially a person in the healthcare professional cares for them. So I think it can be tough for us, and one of the things we've been talking about throughout most of these sessions is support for each other. How do we support each other? How do we avoid burnout? Are things we need to look out. But I think for me, my motivation usually is that I want to see the patient smile. It might not always be possible, but I want to be able to do what I can for the patient under the circumstances. So I think our motivation is that we need to improve the quality of life of this patient. How do we do it? Just to focus on that. Others, if we become so diluted and realize maybe there's not so much we can do, then we might actually give up on the patient. Thank you.
Yeah, I think it's a good point. Sometimes we can be very burdened by the suffering of our patients and very overwhelmed to the point that it leads us not to do anything. And I think especially in light of the topic that we're talking about today, holistic care, finding ways, even in very limited resource settings, to provide support for our patients so that we also feel like there are things we are doing to support them is really important. I do think, Annalice, you and your team have, in a very difficult and very sad situation in which this patient has suffered despite trying all the options she possibly could, with traveling outside of the country, with getting multiple different opinions and getting a variety of treatment to treat her serious illness. It seems like it is not able to be cured, and the treatment that she's done has not led to a situation that's any different than it is right now. And I think that your team is doing what you can to support the symptoms. Her physical wound care seems like it's very intense, and you are not ignoring that. You're doing regular dressings, you're giving advice on the family, you're visiting her, or you're asking her to come to the clinic regularly. I think those are all very important things. I know that you had mentioned the family, the father had shared quite extensively of the current situation, and seems to be how he's coping with the situation. It sounds like you guys are also trying to think of ways to support them as well as caregivers. In this situation, Annalice, have you all been able to give her a prognosis? I'm not sure if you talk so much about this in your setting, but do you anticipate how long she will live for?
Yeah, we tried to give her the medical staff tried to give her the prognosis, but she said she's ready for anything. For her, she's ready for anything. And she will even make joke with you. That's how I get motivated. She will make a joke. She will laugh. She will call you every time. She will call, Mama, where are you? I keep motivated because she always makes me happy. But when you are dressing her, she will make crack joke. She's feeling pain, but you see her pain, but she's again making jokes and laughing. So she keeps us motivated to visit her, and we'll do for her all that we can to keep her at peace and calm, so that when time comes, she will be pain-free.
It's quite interesting in this situation where the physical symptom is so severe and very obvious, with this serious fungating wound on her face. Yet her emotional ability to engage with the staff and the healthcare workers seems to be very positive. And it's almost interesting in a situation where her physical symptoms are very difficult to treat, how she's rising above in terms of the emotional aspect, and finding ways to react with you and engage with you. And it's very positive for her morale, as some of you were sharing. Leah has a really positive comment, Annalice, for your team, saying the team is doing the best in this case, and you really appreciate the family for holding on to her. I know it does really seem like very unconditional love that the family and even your team, Annalice, is showing this patient. I see Liz, Kabuti, or Sarah on the call. Any other comments? Duncan, I see you're on the call with us also. Any thoughts or comments? Annalice, I was a little bit curious about the pain management for the patient. Does she have other physical pain? I know it looked like earlier you guys were treating her with morphine. What is the current situation? And it looked like it was an IM injection. Is that still the situation, or what's her pain?
No, IM was that when she was in the water. was being given IM morphine, but on discharge, we managed to apply for her morphine syrup.
Okay.
So she's using the syrup. And then she also has a naloxone she was given by the eye clinic because she, despite taking morphine, she was still having eye pain.
Yeah.
So she was given some medication for the eye drop and then the naloxone.
And what's her
But most
current,
of the time, yes,
what's her current dose of morphine syrup?
is 10 milligrams, 6 hours.
Okay.
She's comfortable with 6 hours.
Yeah.
Um,
And the team in IRC gave IM, is that because that's what you had access to, or is that pretty common to give IM morphine?
yeah, that time, the IM morphine was given because I was not there, and the pharmacist would not give the syrup out because he did not consult me. So he did not give out the morphine syrup. It can't be kept in the ward. Yeah.
Yeah.
So the morphine injection is given per dose. Every time you want to inject, you go for it from the pharmacy.
Yeah, quite complicated in your setting, Annalice, to provide good holistic pain management, especially in terms of accessing morphine for serious pain and severe pain that she was experiencing. It kind of leads quite good. We continue to have our work groups as part of this community of practice. So hopefully in the next week or so, the morphine team will meet, access to opioids, and we'll talk about this. So that's actually one thing that the team can think about. So in this situation, this woman has had advanced cancer. She has a serious wound that obviously, even just looking at the patient would show how serious the pain is. And even a patient like this has a lot of difficulty accessing morphine. And only once Annalice had returned from her work or her leave or whatever other responsibility she has, was the patient able to get the appropriate route of morphine. Which obviously, Annalice, we're so grateful that you're on the team and there to provide care. But I think it just goes to show that there's still a lot of things we need to do to advocate for our colleagues, obviously, and also our patients. Okay, and there's a few other comments. Liz just sharing that she's learning a lot from the team about providing palliative care in humanitarian settings. Lamek sharing about the good work coming from the team, even though sometimes they've been overwhelmed. The patients had a positive reaction. Yeah, continue to focus on physical pain and improve the hygiene to prevent any further infections for the wound. Yeah, Liz, a really good comment to end the session for today. How do we as a group, as a community now, although Zoom is the thing that's bringing us all together, how do we as a community support each other when we care for patients going through a lot of suffering such as this? And I think that is one of the reasons that we've existed as a community online. We have, as you could tell at the beginning of the session, we've got people calling in, joining the session from Rwanda, Sudan, Kenya, Uganda, Ethiopia, Egypt, and probably more from organizations such as IRC, which is a humanitarian organization, IOM, MSF, Hospice Africa, other public facilities. I think we just continue to meet. We continue to bring cases together. We continue to learn together. Obviously, we have our WhatsApp group for in-between sessions where we can find ways to support one another. I think when you hear about sessions like this and you hear about teams like Annalise's in IRC that continue to provide support despite all the challenges and barriers, we encourage them. We send a message to check in and see how things are going. We are compassionate towards each other, actually. That's how we can continue despite the amount of suffering. I think we must advocate, and we are trying. I know In Kenya, the National Association is going to be visiting the refugee camp, I believe, next week to do some in-person training. These types of visits are really crucial to continue to sustain the morale of staff and continue to improve access to services in terms of training more people. Annalice, any thoughts on how we continue to support each other? What are your thoughts on that?
Actually, you have said it, and that's how even we employ it at a place of work. Although it is not easy, you get one person is on duty, the other side, you are on this side, you have made this case, that later on we can communicate on phone, we consult each other. That's how we manage it.
And I think a lot of us, obviously the majority of our participants in this group are frontline providers in humanitarian settings, but there are a few of us that are not. And I think as much as we are able to support one another, to empathize and understand, I think this group brings people together that are quite compassionate and passionate about being a team and providing good care, finding ways to network. Annalice often messages me and others to reach out. And I think that's one of the richnesses of Project ECHO. We can come together regularly, find ways to support one another and continue to provide care for patients. Well, we are just about at time now. Thank you so much, Annalice, for the case that you've brought together. I know this case has been very meaningful for you. The patient continues to motivate you and your team to do the good work that you're doing. And we hope that you guys can continue to support her. And of course, the family as in times of bereavement as well. Thank you again for sharing. And I will just share a quick feedback form. I know we are on iEcho at the moment, and we would love to hear your feedback based on our teaching and the different work that we are doing at PallCHASE. Let me just get the feedback form. So we'll meet again in another month. If you are able to fill out that feedback form, that would be great. We meet on the third Tuesday of every month. Our next session will be on March 19th. And we will be focusing on another topic related to palliative care in humanitarian settings. Again, if you have any colleagues that are interested in joining us, this is a free training that we offer and community that we would love to involve more people in. If you and your team would like to present a case, we always are interested in having more individuals share and teams share cases. The topic that we have for next month is breaking bad news in palliative care. So we'll be learning some techniques, and that will be taught by Dr. Maha Qasim. She's from Lebanon. And we will have Hassan Mohammed be sharing a case with us in March. So please join us, and thanks for being with us here today. Bye, everyone. Thanks.
Bye.